All right, good morning, everyone. I'm Brianna Yoakum. I'm the Director of Accreditation, and I also head up WAQRR's Professional Development. I'm joined here by Cameron Fordmeyer, and he is going to present today on responding to mania and psychosis. So I've been really looking forward to this presentation. And with that, I'll just pass it on to Cameron. We will have the slides and the videos available after the webinar, and we can send those to the email that you registered with. So,
All right, good morning, everyone. So, like Brianna said, this is a topic that I enjoy presenting on because this is the area that people get the most worried about. Depression and anxiety, other symptoms like trauma, something like that is very much common where you probably know some skills, tips, and tricks on how to work with those individuals, but mania and psychosis due to the high acute and sometimes high intense symptoms of that requires a little bit more effort. And so, without further ado, we'll go ahead and get started. So, a little bit about myself before we get on why I'm talking to you here. I have worked in behavioral health now, which is the term we use for both mental health and substance use disorders for over 24 years now. Cut my teeth in community protection group homes, similar to what you do with recovery residents, except these were high intense people who had been charged with level 3 sex crimes or arson, murders, and sometimes, but they were unable to go to prison because they'd be taken advantage of due to their symptoms and diagnosis, but you could send them to Eastern State or Western State Hospital because they would take advantage of people there too. So we had to monitor them 24 hours in the home, and that's where I cut my teeth right out of high school in. From there, I worked in psychiatric inpatient units and crisis triage facilities. I also worked for crisis services. So I was a crisis counselor and case manager and became a designated crisis responder in 2010. And I still hold that designation. Back then it was designated mental health professional. And I did direct care for a period of time until transitioning over into leadership, where I managed our crisis triage facility and started a couple different programs for Benton and Franklin County, where I reside. Our Prodigal Diversion Program, the True Blood, where we paired up designated crisis responders with law enforcement, as well as jail mental health in there, and then all of crisis services, so both crisis counselors, designated crisis responders, all of that for Benton and Franklin County. Currently, I work for Greater Columbia Behavioral Health, which is our administrative service organization. That area covers Yakima, Kittitas, Benton and Franklin, Asotin, Garfield, Columbia, Whitman, and I believe I got all those 9 counties. And I oversee the Recovery Navigator Program and assisted outpatient treatment for that area. In nights, I also teach for our local community college, Columbia Basin College here, which I treat in the SUD and psychology department for that. And also have the privilege of sitting on a couple boards. So I'm on the Recovery Coalition Board and Youth Suicide Prevention Coalition Board. So enough about me. Let's get into some of the guidelines here. So before we do these trainings, I like to talk about some of these things because there are limitations of training. And one of those is that even though this is for educational purposes, we are not going to come out of here with any added things to our licensure or credentials that we would already have. So this doesn't give us the ability to diagnose. Instead, this is going to help us with recognizing signs and symptoms and how to help our residents when they are experiencing these. So one, how can we recognize, and then two, know the symptoms and the signs that we're looking for and provide some helpful hints on what to do there. There is some issues with confidentiality. So this is, even though I'm a mental health professional, we are not engaged in a therapeutic relationship. So when we talk about examples in here, I will speak in generalities. I won't give any, when I do specific examples, because I find that to be helpful, we won't do any identifying information. And I do have my chat up. So I have the presentation up. I can also see you guys on here, and I have the chat too. So if there is a question, and I recommend that you please do that, because it helps a lot more when you're able to use specific examples. If you can't get away from that, or the question requires more identifying information, send it to me directly and I will eliminate the identifying information. And so I have the chat pulled up. You can just send that rather than send it to everybody, just send it to me directly and we'll still address that. Also, despite everything that we talk about here, you're always going to have to follow your governing bodies regulations and your employers too. So always stick to your protocols or your policies and procedures. One of the things that I'm going to try to hold myself accountable with is use people first language when we talk in here. And so uh, we do it in the medical field where we don't say the cancers or we don't say the heart attacks, but for whatever reason in behavioral health, we still say the schizophrenics or we still say druggies. So we're going to not talk with pejorative language. We are also going to refer to people as them with living with these diagnoses. So I will do my best and try to hold everybody accountable that we are going to try to speak appropriately and properly when we talk about these things. Also, I am going to try my best to not use acronyms. We love our acronyms in this field. And so when I say the person was high on PCP, diagnosed with ODD, referred to PDP, and who's down with OPP, you know me. Call me out and I'll explain what the heck I'm talking about when we go through and use a bunch of acronyms for that. And then the other one is the parking lot. If you do ask me a question and I say I'm at a parking lot, that's not because I've offended you to come fight me and meet me in the parking lot after school. That's so we'll probably address that question later on, or it requires a little bit more explanation to what we'll put that at the end. So feel free to ask questions and do that. So our objectives today, we're going to become more familiar with the signs and symptoms of mania and psychosis. So you can see that, spot that, and recognize what those are. And the two differences is signs are things that we can see. Symptoms are things that we either have to ask about or the person tells us about. So that's the difference between the signs and symptoms. We also want to have a better understanding of how to assist those experiencing those symptoms, especially if they haven't experienced them before. They can be pretty scary. So we can do a better job of helping that person as much as we can to eliminate any crisis issues or any further trauma for other residents or themselves. A lot of times we talked about the acronym stuff, but we use very complicated terms to describe sometimes things that can be more simple. So we're going to gain knowledge about complicated issues, but hopefully put them in an easily digestible way so that we're using layman's terms and we're not getting overly complicated describing something that we could just better use in normal people talk. And then ideally, we want to improve your confidence and empower attendees to effectively manage these symptoms. All right. So when we're talking about this, like I said before, uh, the most common issues that are going to occur in a crisis issue is going to be for somebody experiencing mania and psychosis is they probably have a bipolar disorder, either a schizophrenic disorder or a schizoaffective disorder, which is a combination of both. So they have symptoms of mania and psychosis. So these are the common areas that we're going to be dealing with those diagnoses. That doesn't mean that they will not have sometimes homicidal thoughts or suicidal thoughts or anything like that, but these are going to be the most common issues that occur with this type of diagnosis. So we're going to stick to mania and psychosis for any type of crisis issues for this. The other thing that I want to bring your attention to is when we have mania or when we experience psychosis, sometimes this can be drug induced. And so either it could be prolonged for extended substance use. It can be alcohol related. It can be sleep related. It does not have to, just because you experience mania or psychosis, have these diagnoses. And when we have these symptoms, we treat them the same way, whether they are organic and they're genetic and we were born with them, or whether they are drug induced or alcohol induced. And we treat them the same way in the psych hospital. So, same medication, same ways of assessment. There isn't two routes that we would go for this. So let's talk about what mania is, though. So before we get into recognizing it, we have to understand what mania is. And so when we talk about mania, this is a distinct period. Okay. So this is abnormally. We all have traits. So we all may feel like these at times. So please don't diagnose yourself. Please don't diagnose others. This is something that is going to occur for a distinct period of time rather than just we appear to be irritable at times. We appear to be grandiose at times. Everybody has traits of this, so we're going to separate from the disorder element of just having traits of this. So mania is a distinct period of abnormally or persistently elevated, expansive, or irritable mood and abnormally and persistent increased goal-directed activity or energy. And we're going to break these down each category as we progress. So if we start getting into there, but feel free to shoot me questions if you have them, but we're going to break these out as well. So it is a core feature of bipolar 1 disorder. You may have heard of bipolar 2. You may have also heard of cyclothymic disorder. These all have elements of bipolar, but with mania, that is particularly related to bipolar 1 disorder. So symptoms must be at least 1 week and be present for most of the day, nearly every day, and any duration of hospitalization is necessary. So what that means is, like we said, just because we get into some of these symptoms, you're like, oh man, I have them, because I have a lot of these symptoms myself, right? Most people will. The difference would be, are they causing disorder in your life and the length of time that they are occurring. So there's also a mood disturbance in there where severe enough to cause marked impairment in social or occupational functioning and necessitate hospitalization to prevent harm to self or others. So what that means in there, what we're talking about is, if something is truly a disorder, it affects multiple areas of life. So you could have symptoms of mania, you could have traits of these things, but if you're able to maintain employment, if you're able to still continually improve with education or go to school, uh, and it's not causing problems, that's one area that wouldn't be affected. The other is your ability to maintain healthy relationships, and not just romantic relationships, but relationships with coworkers, relationships with family and friends. So if those are causing severe problems in there, or you're going through relationship after relationship, you're burning bridge, losing jobs after jobs, so on and so on, that's another sign. And the other piece, which we'll talk about a little bit more of grave disability, will be your ability to take care of your basic needs. And yes, Bree, we will get the slide deck available for Carmen after this. I will make sure that you have that. See, I'm on top of you send them in real time and I will respond. All right, so let's tackle some of these individually so you have a better idea of what we're talking about in here. So the key behavioral symptoms of mania, when we talk about elated or expansive mood, okay, we've all been in happy moods. We've all had times where we wake up and we just feel really good. We're feeling ourselves today. Somebody said something we liked, whatever that is. We got stuff to look forward to. So this is excessive, though. This is cheerfulness to the point where we would talk about euphoria, right? Or it's a extremely high feeling. This is also why people who experience mania do not want to take medications for it, because they feel good. They feel like, this is awesome. I'm the best ever. I can do this. I can do anything. It doesn't even matter if something's going wrong. They're still feeling high, right? They crashed their car. They spent all their money. It doesn't matter. They still feel really good. So getting somebody to say, hey, you're not supposed to be feeling that good. You're not supposed to be riding that wave. They're going to tell you, kick rocks. Like, I like the way this feels. So this is hard for somebody to take a step back and go, okay, I need to be brought down. And sometimes with the medication that we use, they tend to feel like they're a zombie. They tend to feel like they're slow and they're sluggish, when to us, it's how everybody else would be responding, right? It's a normal level of that. So continuing on that, there's an unusually optimistic or upbeat, even when bad things are happening, right? They just had a breakup, they just got caught cheating, but they don't care. It's no problem, right? Even though there's a fallout of all that, they're still on to the next, feeling really good. And it may seem overly friendly or intrusive. So sometimes you experience people who have no personal space issue. They're up in your business. They're asking you very personal questions. They have an extremely, big, large smile on their face, and you're not really understanding the whole personal space issue. This may fall into that category where they're asking you questions to where you would be like, hey, I wouldn't tell people, my friends, that, let alone ask you or tell you about that. When we get into the irritable mood stuff, and this can switch back and forth. Now, we know people can be, the term we use for this when we use big terms is labile, right? They go from angry to sad to mad, back and forth over and over, to elated to angry again, and they start crying and they're in tears now. So the irritable piece of that can go with the euphoria, and they get easily frustrated. They're quick to anger for that. Usually the two things that will happen in there is that one is that part of the grandiosity, and we'll get into that too, of where they start having big dreams or big hopes or stuff that they thought was going on, their plans, their desires, they're thwarted for whatever reason. Maybe it's because of reality, maybe it's because of criminal activity, maybe it's because of rules or regulations. But as soon as that happens and it interferes with that excessive or that upbeat, they're going to be quick to anger or quick to frustration. The other thing that happens with that too is sometimes it has to do with racing thoughts. And the easiest way to explain this is for those of us who have kids or those who have jobs and we have multiple things going on at once, and we're worried about this and we're worried about that, and we have somebody just in our ear asking and repeating the same questions over and over, and you get really frustrated. That's what it's like for them when they're experiencing their racing thoughts, is that they're having so many thoughts go in and you're interrupting those, and they're quick to anger for that too. So there's going to be both an elevated mood to that and an irritability element of that. The other thing that you're going to see that is distinctive from other things is an increase in energy or activity. So uh, when we get up in the morning, right, they're already doing three different things. They're making coffee, they're cooking breakfast, and they're on the computer doing something. They have a noticeable increase in goal-directed activity. And that can be both work related, that can be school related, that can be social, or it can be sexual related. There is an element of mania that people get sexually and religiously preoccupied in this. So it can be that they're dating multiple people and they got multiple Tinder accounts going and they got all this type of stuff all at the same time. So you're going to notice that this isn't just one thing that they're excelling at. They're doing multiple different things on here, right? The other piece is that they're going to be feeling restlessness or fidgety pacing. They cannot sit still. They're easily distracted, right? So when they're taking on multiple projects at the same time simultaneously, they got a lawn care business. They also have a cleaning business. They also have a Facebook account that has this business going. They have participated in this, but you know that that's too many things. To them, it's not, right? They have all these projects going and they're going to knock them all out of the park on that. Now, somebody says, this looks pretty good. Why would I have an issue with this? If I have an increased in energy and goal directed activity, I can do all these things and I can do multiple things and I can have multiple relationships. It sounds pretty good. And to a certain extent, you are right. If you can manage these things and you can do it without creating other impairment in your life, you can be a very successful adult and high functioning person if you can manage this. Now, the problem with that is that you are burning the candles at both ends, and you can only do that for so long till there starts to be a crash in that, right? So we'll get into some of why that may be. So other parts of manic symptoms, when you have a decreased need for sleep, some people require very little sleep. Some people sleep and require naps all the time. But if you require little to no sleep, eventually that is going to catch up with you, right? We've done tons of sleep deprivation studies. And if you go more than 72 hours without sleep, you are more likely going to start hearing things that other people don't hear. You're going to see things that other people don't see. You're going to start experiencing some symptoms of psychosis if you don't get sleep. So if we were able to do those things that we talked about on that slide before this and manage them and get sleep and get food, then yeah, you could still maintain that and be very productive. But without that, there's going to be a crash in there. And so if you have residents that are operating off a little no sleep, the 2 to 3 hour window, or they're feeling like they don't need sleep at all, they can stay up the whole 24 hours, right? In my younger days, that probably wasn't a problem. But if I go without a good night's sleep, I feel it these days, right? So decreased sleep is going to be a huge warning sign there that we want to pay attention to. We also have racing thoughts and flight of ideas. So those are thoughts moving very quickly from one idea to another, and usually there's no gaps in that. So you've probably all experienced talking to somebody who doesn't have a gap in their thinking, and the topic switches from topic to topic. It goes from relationship to work, and it goes from work to goals, and it goes from goals to dating. And then there's no gaps in the thinking. It just goes on and on and on to the next. So that's another thing that we can pick up on. If their thoughts or their ideas have no gaps and there's difficulty on that transition. So they may say that my mind works too fast, right? I'm constantly thinking about the next thing, which will lead to another sign, which is going to be pressured speech. So that I have had to learn to talk slower. I want to talk very rapidly. And I had to learn, especially working on the psych hospital, especially working with individuals in mania and psychosis, that I couldn't mirror that. I couldn't talk really fast and talk like the micro machine guy. I'd have to purposely slow that down. Because if you don't and you talk very fast with them, that is going to increase that. So, talking rapidly, loudly, often without interruption. So, their speech may be difficult to interrupt. So, you're trying to get onto the next and tell them, hey, we have an activity to go. You have a schedule. We have, group time, whatever it is that you have an appointment to go to. They're hard to interrupt. They're going to keep talking through that, right? So they're hard to interpret and hard to interrupt. And it often is connected to those racing thoughts and flight of ideas. Their mouth is trying to keep up with their ability for their brain to go from topic to topic. And so it is reflective in their thoughts as is in their speech. The other piece of that is easily distracted. And this can be, especially when we're trying to work with somebody or do something important. Maybe we're doing a crisis plan with them. Maybe we're trying to uh, get their appointment scheduled. Maybe we're doing stuff and they keep being distracted by a bird, or a beep from the microwave. It doesn't have to be anything big. They're easily distracted by unimportant or irrelevant thing and external stimuli. So anything and everything that goes on, they're responding to. Side conversations, the phone rings, they're all over the place in that. So they have a very hard time staying on focus on conversations or tasks during that time. So other issues in here, and this is where we start to get into more of the things that you would see in crisis triage facilities, psychiatric hospitals, withdrawal management facilities, so SWIM facilities, when we start getting into the grandiosity or inflated self-esteem. So it is important that people have good self-esteem. It is important that they feel like they are important, that they matter, that they can do and have hope to do these things. But this gets a little blown out of proportion, right? So this starts to become unrealistic beliefs about one's abilities, power, or importance, right? Not that they feel like they matter, they feel important, they feel like they have special powers or things that stand them aside from others, that they are somehow better, more important, or more relevant than what they really are, right? That becomes, and we have all have deal with people who inflate stuff. So maybe they have a music career and they talk about their show, and yes, it was attended by 50 people, but it was the greatest show ever, right? So it's not to that level, it's to the fact that you can tell that there is something wrong because what they're talking about appears to be superhuman, or it appears to be that they're more famous, or that they have a connection with somebody that they don't really have connections with, or they interpret things that an email, right, was, even though you sent it out to everybody, it's specific to them. So they may believe that they have talents and insights and connections that they don't really have. And that's where you get sometimes where the people who celebrity stalk, right? They think that a song is specifically about them. There's a correlation there. And so somehow that person has a tie to them, or there was a special message in that song or that show that had to do with me. So that means that I need to do A, B, and C, right? They can also have a range of unwarranted self-confidence and delusions of grandeur. So when we talk about grandiosity, that means that when they're grandiose in their thinking, that they have the ability that others don't. They have special powers, all of those things. Now, which gets into the danger area of this is there's nothing wrong with having religious ties, right? But when you have specific messages from God, or you have a special purpose that was handed down to you from a higher power, you are far more likely to justify those actions and want to do those things, right? So there's been a couple times to where we've had to intervene with people knocking on people's doorsteps, and people are having dinner or whatever it is, and nobody likes to get bugged while they're eating, but they have a special message and they don't take the hint that they need to leave this person's property because they were meant to be there. They were God's messenger. They have to do that. So you may see times, and we talked about the sexual preoccupation of that, but there is sometimes a religious preoccupation in this, especially if somebody already has ties to a church. They may take that one step further and may take it as a mission, and it starts to be more of a command hallucination, that they are made to do these things, and if they don't do these things, there are going to be severe consequences for that. So the other piece that we want to worry about or know about is the impulsivity and risky behaviors, right? So engaging in activities that have a high potential for painful consequences. So what I mean by that is spending all of the money that they would have for rent or groceries on a Pokemon collection, right? They would spend their money that they had to give for child support on out to eat or out trying to impress people, or they bought a car before they had a solid place to stay, right? They got a car that they didn't have room to have. I have a coworker who has a good example of this where he was with a friend who was in a manic episode, and the person at the took a liking to the person at the McDonald's counter, and so he naturally gave them his watch that he had, which was a Rolex, and gave a diamond pair of earrings that he was going to purchase for his girlfriend, just to the person on the counter, right? Didn't know this person, didn't anything. So there's a spending element that can be disastrous, especially if we're trying to budget for people and trying to get them to understand priorities, and they're recklessly spending money on stuff that they shouldn't. The other one is indiscriminate sexual encounters. So there may be a need for additional, how do I say, dopamine, right? They are craving other stuff, and one of those things that happens is with sexual encounters. So they may have multiple sexual partners. They may be increasing that number to multiple sexual partners within the same day, and it can also be unprotected. So now we have a STI problem, or we have unwanted pregnancies, or we have cheating, and so then they now you have significant others who are upset, or people who got cheated on who are looking for them. So there's all types of fallout that can happen from that as well. Foolish business investments, gambling, substance abuse, all of these things that could be reckless in nature are going to be increased when we have times or symptoms of mania in that. So they may have put all their money in the new, Bitcoin, or they have put everything in because it's going to hit on this next business venture for AI, right? They're looking for the next greatest thing, and they're putting all their money into that. Or they watched the World Series of Poker, and now they're going to go down to Vegas and they're going to get into gambling, or they know the trick to a slot machine. I used to work with a gentleman who thought in that he could dumpster dive in the casino's dumpster, and somehow the receipts of that would crack the code for him to use the right slot machine. Now that sounds odd, right? But to him, that was there. So he would do that. He would go to Wild Horse. He would go to a couple of our local casinos here, and he would dumpster dive in their dumpster, and then he would go to what machine he thought was that. And he thought he cracked the code for this. His family ended up having to take power of attorney because this was a fairly wealthy individual, and he was blowing through the family's money for this with little to no insight into why this was a problem and how that didn't make sense to this, right? So there may be poor judgment, lack of insight into all that potential harm area. The other instance that we talked about, and why we'll discover later when we talk about mania that it has psychotic features, is because when you go without that sleep, like we talked about earlier, you're not taking care of yourself, you can get pretty psychotic with auditory and visual hallucinations, especially with delusions. And we'll talk about the difference between hallucinations and delusions in a little bit. So when we have delusions, these can be fixed beliefs, they can be false beliefs, believing that somebody is famous or has special powers, or just has to do this one gig and they'll get famous by doing that. Post their song to SoundCloud, and they'll get picked up by an AR group and get signed to a record label and go on a tour. They just need to meet this person. If they could just give this person their demo, they're going to be great, right? We also have hallucinations. Hearing voices is going to be the most common one, but we'll go over the other type of hallucinations as well as where they may come from. And then we have the features underscore the severity of the urgency of the manic episode. So sometimes we can justify these things without understanding the importance of the problem areas for that. So talked a little bit about mania. We'll talk more about psychosis now, and then we'll get into how to help or how to talk to individuals with that. So when we are talking about psychosis, the most common diagnoses that are associated with that are going to be schizophrenia. Now, schizophrenia is a organic schizophrenia, I should say, where you're born with that, or there's a genetic component to families that you have symptoms from that, is pretty low when percentage wise. Most people are going to have depression and anxiety issues. Everybody has trauma issues. Those things are very common. Having true schizophrenia, even though you hear about it a lot because it gets glamorized in the media that a school shooter had schizophrenia. So you hear about the diagnosis quite a bit when the prevalence of it is actually statistically really low, right? The other thing that happens with this is that we tend to think that they're scary because they're yelling and screaming, but really they're yelling and screaming at the internal voices that they have, right? So when we hear schizophrenia, we hear this, we see this, we get a picture in our mind, and we think some based on media or based on stigma that these individuals are more dangerous than what they are, but they are typically victimized a lot more than they are ever victimizers. And we'll talk about the symptoms and why those two things may coincide of why people think that. And then we have bipolar disorder because of the lack of sleep, lack of taking care of yourself. You may develop psychosis. Same thing with depression. We have psychotic depression. That's for individuals who have not been eating, not been sleeping. They're going to have that. We talked about schizoaffective disorder, which is having elements of mania and schizophrenia. So you both hallucinate and have mania, which is extremely hard to treat. And then we have drug induced psychosis, which is primarily most of what we're going to be seeing in psychiatric inpatient units at secure withdrawal management facilities are individuals who don't have organic schizophrenia, but they have drug induced psychosis and they've done permanent damage to their brain or have prolonged effects to that to where it mimics symptoms of schizophrenia or mania. And again, we treat it the same way. So there is no difference in how we would treat that. All right, so what is psychosis? Psychosis is a condition in which a person has lost some contact with reality. And we'll get into some helpful hints on how you decipher on what and where the issues may come from here in the next few slides. But the person may have severe disturbances in their thinking, emotion, and their behavior. So it can affect their ability to think clearly or think properly. It may mess with their emotions. So they have inappropriate emotion element of that or don't have appropriate responses that we would deem appropriate to certain emotions like anger or jealousy or fear. And it also is going to affect their behavior. So disorders in which psychosis can occur are not as common as depression and anxiety disorders, but they, like we said, get more attention to them because of they may be scary, they may be loud, they may be boisterous, they may have same thing with the mania element, they may have severe consequences due to their grandiosity or their sexual problems or gambling problems or whatever that may be. So they aren't as common, but they definitely stand out more than the other. And then psychosis usually occurs in episodes and is not constant or static condition. So what I mean by this, and another fancy word to write down is called malingering. With true psychosis, you cannot turn it on and off. So you will have bouts to where it's very, very heavy, right? To where they're symptomatic, they feel it, it's almost too much for them. And then the wave dies down to where it's manageable, so they can have a conversation, they can cook a meal, they can do stuff, but it doesn't go away, right? So it is there and it's a static condition to the point to where you don't experience it and then not experience it. It is occurring in waves. So the easiest way that we were able to diagnose what we say malingering is faking that or exaggerating the symptoms is when people say, if I have this, if you give me this, right, it will help with my symptoms. If you do this, it will help. You can't bargain and you can't make deals with the symptomology. You can say things like excessive stimuli, right? And that's sometimes where you see people walking through the mall or you see them with the headphones in, and people will say that does help. Smoking sometimes help. That may be true, but you can't give me something from a manipulation standpoint that will help with my symptoms. And if you don't do that, I'm going to be more symptomatic. right? So when we talk about these things, there isn't a on and off switch for them. They are there. They're just the intensity of the waves is going to be the one thing that matters for that. So, getting into a couple different things that will help you decipher or understand the difference between some of these. So, when we talk about psychosis, again, that is someone who has lost touch with reality and is experiencing hallucinations, delusions, and/or paranoia. So, we'll talk about those specifically. So, delusions versus hallucinations. This can get a little tricky for people and may not know the difference. So, the easiest way I can describe this is if I am telling you that I am Jesus or the next coming or the messenger of God. That is a delusion. I think something, I feel something, I'm telling you, so I am Jesus, I am the messenger. That is a delusion. A hallucination would be that I hear Jesus's voice, I hear the messenger, I see the messenger. So, two separate things. Delusions are things that people think and may contribute to them. And hallucinations are things that they experience that other people aren't experiencing, which sometimes I have the pleasure of getting calls from your residence owners, right? And they want to go over documentation or want to ask questions. One of the documentations that I was able to look at before was somebody documenting on one of the residents that they said they were hallucinating. And the resident said that they appeared to be hallucinating because they looked up at the ceiling and they focused in and they thought they saw spiders. But later on, after looking a little bit closer, it was really dust on the fan and dust on the ceilings that resembled spiders. So that is not a hallucination. That is called an illusion. So when we talk about these things, it's important to know the difference between an illusion and a hallucination. So an illusion are things that we think we see, like what magicians do, but really it's something else, right? There's a different explanation for that. So if I come down at 3 a.m. into the kitchen and I look outside and I see a figure standing there, and I turn on the light outside and it's really the moonlight shining through the trees that look like a figure was standing there, that's an illusion. That's not a hallucination. Now, if I see spiders on the ceiling and I move and shake stuff and there is no dust and I still see spiders, but nobody else does, right? Similar to that same example, if I go down at 3 a.m. and see somebody on my porch and I turn the porch light on and off and that person's still there, but nobody else sees that, that is a hallucination. So the difference between illusions and hallucinations, we have to be very careful that we're not interpreting things incorrectly or that we're providing some clarification questions of are we really seeing an illusion or is this person truly hallucinating? Because they're two different things and two different courses of actions. Illusions are going to be things that we just mess up and see, like I said, the magician piece of that. So the other thing is that there are different types of hallucinations, but how they manifest is important because you may be dealing with something else that we think is a mental health issue. So when we talk about types of hallucinations, the most common that are going to occur are going to be auditory and visual, more so auditory. So somebody who has schizoaffective disorder or is living with schizophrenia, they're going to experience voices. They're going to hear things that other people don't. So there's going to be an auditory element of that. The other piece that they may experience is visual hallucinations. They may see things, colors, shapes, people, things that other people don't. Those are typically going to be related to organic schizophrenia or drug-induced psychosis to a certain element. Now, tactile hallucinations, that is where people feel like they have bugs crawling on them. They have things inside their skin. Somebody has implanted things and they need to dig it out. There is something going on in my body and I can feel it, but nobody believes me, right? So tactile hallucinations are typically related to drug use and most likely related to stimulant use. So that is probably going to be something that if your residents are experiencing tactile hallucinations, it might be time that we want to UA them to make sure that there isn't something else that they've taken that is going to be the reason why they're having tactile hallucinations, because that is typically not something that somebody with schizophrenia or schizoaffective disorder will have as a type of hallucination. The other one is olfactory or gustatory, which is olfactory is smelly. So somebody who says, I smell sulfur, I smell, something that I smell something, or it may be odd. They may talk about smelling something that is a sound or a color. Same thing with gustatory. If I taste iron, I taste metal, I taste something in there. So if those are smelling and tasting hallucinations, typically that is going to be related to a head injury. So somebody has got a traumatic brain injury, a concussion. Those type of hallucinations are something that we want to get that person probably checked out medically, because maybe they got into a car accident recently. Maybe they bumped their head doing something physical, right? So there may be something else that we want to take a look at if those are the type of hallucinations that they are mentioning. So common symptoms when psychosis is developing. So what we will look for in their thinking or their perception. So when you see somebody, and if you haven't, when we do these in person, I can usually ask people and raise their hand. So it's a little bit more difficult now. But you may have seen something that we call response latency, right? I ask a question to the person and it takes them with a blank look on their face several seconds, if not longer, to respond to something that shouldn't have taken that long to respond to. So, for example, when I would be on the psych hospital doing people's intakes, and I would ask, the demographic stuff, their name, no answer, staring blankly. Where do you reside? So on and so on. And I'm going all the way down to the fourth question, and then they tell me their name. It took several minutes, if not seconds, to answer simple questions. They're going to have difficulty with concentration and difficulty with attention. So there may be a sense of alteration in others or the outside world. So they may think that they've changed or you have changed. And this is even more difficult with this day and age when we have algorithms that feed us stuff that we were looking at. You just talked about Snickers and how much you like Snicker bars, and then this thing, you're getting an ad for Snickers, right? Or a new type of Snickers. Or you were talking about a product, and all of a sudden they have everything, and you're receiving a message on that. So that happens normally, but this is something that is very difficult for these individuals because they're receiving messages from the outside world. They have a sense that you now have planted that in them, that you are tracking them, that you're following them in some way. They may have odd ideas related to that, right? So there is going to be a paranoia element to that, that maybe you are not who you think you are or say you are. And whether you know it or not, you're a part of a delusion. You're a part of a paranoia. You're a part of that. And we'll talk about how to handle that too if you ever get asked about that. If you ever get told, are you seeing this? Are you a part of that? Do you experience this? How we answer that without agitating the person worse or making the person have more exacerbated symptoms. So there could be odd ideas or unusual perceptions experiences, right? They may say that they taste colors, they taste sounds, they smell colors, they confuse things, or they may have odd references of that. So if they start saying that, that's going to be something to perk us up. Very similar to mania or anything when we talk about depression and anxiety as well. Changes in behavior, one of the easiest things we can do is sleep disturbances. So have they been sleeping well? Have they been getting enough sleep? Or are they not sleeping at all? So changes in behavior, the first thing we're going to notice is sleeping disturbances. The other one is going to be social isolation or withdrawal. Now, when we talk about symptoms of psychosis, there are two categories that we can talk about. One is positive symptoms, one is negative symptoms. These don't have a point value. That doesn't mean that positive symptoms are good and negative symptoms are bad. They are, when we say positive symptoms, those are the things like paranoia that is occurring. Those are hallucinations. Those are delusions. Those are the positive symptoms that something is occurring to them. The negative symptoms is the withdrawal, is the fact that they want to be left alone. And is that a couple different reasons why when people say, well, why does this diagnosis typically result in homelessness? It's because they want to withdraw from society. They don't want to be around others. They want to be left alone. They don't trust people. This is why you see people with foil in their windows, right? So that you can't see in, or why they don't engage in mission or places to stay that would be more of like, hey, where are you staying on the table? Well, they don't want to. They want to be left alone. They don't trust other people. So those are negative symptoms of this. social isolation withdrawal. They may stop hanging out with people. They may want to be in their room alone. They may want to be out for periods of time and only come back when they have to be. And yes, this will be recording, and I will send out the slides too, David. So back on the reduced ability to carry out work or social roles. When you are, and if you've never taken one, I suggest that you probably do just to experience it, is they have simulators sometimes for psychosis. They will put you up on, get a laptop in front of you, get a headset on, and you can kind of experience the stuff that they would be experiencing. Now, there is no 100-bit way to experience it like somebody who is actually experiencing it, right? So we don't say, oh, I took a stimulator and I know exactly what you're going through, because the two do not equate, right? But when you are experiencing it, is extremely hard to carry out work or engage in social activities, because it is the equivalent of having the TV on, having one earbud in, listening to music, having somebody talk to you in another ear, and having a bunch of stimuli like sounds, sirens, and everything else going on in the background. So it's extremely hard to decipher all of that. And that's why we see that response latency where they're not responding. They have a flat affect. They're not responding appropriately to what we're saying. It's because they're filtering out so much stimuli that it is really hard to carry out normal tasks, right? So that's where we have to have some empathy into that these people aren't lazy. They're not stupid. They're not anything negative. They're experiencing some stuff that is probably pretty terrifying, let alone hard to do normal activities with. So moving on to more common symptoms that appear with psychosis. So changes in emotion and motivation. Their affect may change. And affect is another one of those words that we use big. It's for facial expressions when we say affect, right? So normally they'd be smiling, they'd be appropriate. Now there's changes in that may be blunted, or that may be flat, or they may have an inappropriate. We're talking about something serious and they're not responding in the appropriate way that somebody we would think with the topic area that we're talking about would respond to. There's going to be increased depression and anxiety, and of course, irritability in that. They may be more suspicious of what you're doing, what you're writing down. Why are you writing that? Why do we have to do that? Where is that going? Who does this report go to? Why do I have to do? Where's my information being sent to? There may be a little bit more suspiciousness or paranoia element of the information that you're gathering or why you're asking them questions. There can be changes in appetite and reduced energy and motivation all around. So these are just more common ones that will occur. But the blunted or flat affect is one that you see quite frequently with everybody. Some of these things may have some range or variation, but typically somebody with psychosis is not going to have the normal rate, rhythm, and flow of conversation or their facial expressions. All right. So why do we talk about this stuff? Why do we care? Right. Well, we talk about prevention work as being important for things that we make sense of, and I'll tie it to something else unrelated to the topic that we're talking about, right? Like sex education. Why do we provide sex education for kids at an early age? Well, the consequences of that are unwanted pregnancies, unwanted sexually transmitted diseases, right? They have it may be something that they're not ready for. We understand that, so we provide some early intervention because there are long-term effects that can happen from choices that are made that will have long-lasting effects on somebody, right? So we can wrap our brain around why we want to intervene early and why we want to do some prevention. But when we are talking about mental health symptoms, we don't want the person to have poor long-term functioning for the rest of their life. So what I mean by this is, and I have permission to do this, I have a cousin who was very artistic and very clever and witty and had a bright future. He started dabbling with meth at about 15. And it was very significant that his ability to adult, for lack of a better term, or his ability to transition to higher level of thinking or higher was stunted by that. The meth use did irreversible damage to his brain, to where now we're not children anymore and we're 40 and 50-year-old men. He still thinks like a 15-year-old kid. and you can't get certain things or certain concepts out of that because without early intervention, that did some damage where his long-term functioning has been stunted. So same thing can happen when we have episodes of psychosis and episodes of mania. When you have episodes like this, you are doing damage to your brain. And when you do damage to your brain, it is hard to gain that back. So this is the equivalent of every psychotic episode, every manic episode, every time somebody has to go into secure withdrawal management, every time they get detained to a psych hospital, they are doing permanent damage to their brain to where their baseline drops. It gets lower and lower and lower and lower over and over again to where you can see that how they were at one point before their use or before they became symptomatic, right? That drops. So we don't want poor long-term functioning for somebody. We want to intervene early in this, and there is no such thing as too early, right? So even if there has been damage done, it can get worse. So we want to intervene before that can make the fact that they are going to have a hard time functioning later on as that baseline drops over and over. There's also going to be increased risk of depression and suicide. So we have to keep that in mind too. We talked about the slower psychological maturation, slower uptake of adult responsibilities. So that made to the point where, like, okay, hey, you're no longer a kid. You have to get a job. You have to pay bills, but they don't have that same concept. It's similar to where I'm talking to my elementary school kids, right? There's also going to be other strain on relationships and subsequent loss of social support. And as most of you know, we need a lot of social support when we are dealing with addiction issues. If we don't have outside support, we don't have internal support, we don't have family or romantic support, it is really hard to stay well and be in your recovery from both behavioral health issues and substance use issues if we don't have that social support. So if we constantly are dealing with people in psychosis, dealing with mania, those bridges are going to get burned. We're going to do damage to relationships. They may still love their loved ones, but they don't love the addiction. They don't love the problems that come with that. So they're going to lose some of those social supports if we don't intervene in that. The other one is going to be disruption of employment and education. It gets harder and harder when you take breaks between education or work to get back into it. It also messes up our ability to gain better jobs or further our education in that. So if we are constantly disrupting those things and our work history looks spotty, or we started an AA degree and we never finished and we have to go back, the more you wait, the harder it is. So if we can intervene and not disrupt somebody's ability to maintain employment, interrupt their ability to further their education, the better. We also have greater chances of problem with the law. And as a lot of us know, when you have certain criminal history, it becomes harder to get on insurance to drive in a peer position. It gets harder to obtain certain positions or get credentials to go into a jail or do certain things that now we're trying to get back into employment or trying to get somebody some means to provide for themselves. But if we have a longer criminal history, it may create some problems with that, right? And no matter what, even though we're doing a good job of getting people out of jail and directed to treatment, sometimes the criminal justice system is not designed to get you out of it. It's designed to keep you in it. So if we have those problems with mania and psychosis and they result in incarceration, it is really hard to get out of that too. And that can create further problems with that. So this is why we want to intervene and intervene as soon as possible because of the consequences that can occur from this. They can be all over the place. They can be criminal, they can be relationship, they can be educational, all of these things. We want to intervene as soon as possible so that people have the best odds for success in their life. So how to accept or help with mania in general. So approach the person in a caring, non-judgmental way. Now, that sounds like a duh, but sometimes the easiest things to do that we talk about are the hardest things, especially when we can have people who are being annoying. They're saying inappropriate things. They're doing inappropriate things. They're acting in a way that would warrant judgment, right? So having to put that aside and understand that symptoms are symptoms and it doesn't mean people are bad people, we need to approach them in a caring and non-judgmental way. Sometimes that means that we need to wait for a private time and place. We can't call them out in group. We can't do it in front of people. We need to do, especially if they're already having internal stimuli, meaning that they're hearing voices, seeing things, they're easily distracted with that mania. We need to have them free from those distractions. So in a nice quiet area that is just private that we can actually talk. So when we do that, we need to let the person know that we are concerned and that we want to help them. That should be the first thing that we talk to them. Okay. Now, we don't want to psychologically corner this person and just say, I'm concerned about you and leave it at that. We need to add some stuff to that. We need to say, I have witnessed you pacing throughout the entire day talking to yourself, or I have seen you spend all of your money on, like we talked earlier, Pokemon cards when we have rent due. You need to say the specific thing. We don't want to just leave that generic. So you let them know that you're here to help and that you're concerned with this behavior that you're seeing, right? We state that specifically. Then we have to be sensitive to the way the person is behaving too. Okay. If they are agitated, if they are very depressed, we need to keep those type of things in mind. So we want to let the person set the pace and the style of the conversation. If they are agitated and it's a fast-paced conversation, okay, we want to do our best to try to slow that down, but we let them dictate that. If they have little to no energy and they're very sad and on that depressive element of that mania, which does happen, and that's worth talking about, is sometimes there is a flip side to that mania where they get very depressed, but it's not a normal depression because they may be dealing with the fallout of all the mania. Now, we talked about the inappropriate sexual relationships. Maybe their significant other found out and now they're getting a divorce. So now we're dealing with that. They have no more money and it's their kid's birthday, right? So now they can't even have a present, let alone have to find out for their rent. So we may be dealing with all of the fallout and all of those ramifications from that manic episode to where now they're in a deep, deep depression because there are consequences for those actions that they're having, right? So we need to let them dictate the style of the interaction and that pace of that. It could be really high, it could be really low. We also never ever want to, and I know this is another but we as people want to touch people's shoulders when something, or we want to touch their hand, or we want to touch their knee, or pat them on the back, or we want to, in this case, we don't touch anybody, especially not without permission. Okay. So some people really like physical contact. Some people don't want to be touched at all. In this case, we're not going to limit their or restrict their movement, and we're not going to touch them in that. Okay, so we do want to create that separation, and usually 4 feet is reactionary distance of worst case scenario that we still have time to response if they do get upset or we get pulled into a delusion or a paranoia with that. So try to keep a decent amount of distance and allow that person to talk about their experiences and beliefs if they want to, but we're not going to force them. So if they are trying to tell you about a delusion, if they are trying to tell you about a message from God, if they are trying to tell you about a special purpose or power they have, let them talk, let them get that out. Okay. And again, we do want to do this in a private spot to where we are respecting that person's responsibility or their privacy. So initial approach, first and foremost, and when we do de-escalation training, which is a whole 8-hour training, we're just doing a little brief slide on it right now. One of the first steps is mental conditioning, is to get your brain in order, right? To know that you could walk into your place of employment and have to deal with somebody who's psychotic, right? Have that understanding that this isn't somebody who's bad, this isn't somebody who's upset, this is a person who needs our help. So we have to keep our mind right. We have to be free of our own financial stresses, our own relationship problems. We have to keep that stuff in check, be patient, and stay calm in that. We also want to establish a safe environment, so physical space, and we talked about removing potential hazards in that. So that could be that we have to remove pins, we have to remove sharps, we have to remove certain substances. Like, for example, sometimes we would have to remove water and coffee from the inpatient unit because somebody is repeatedly drinking over and over to the point where you can get water intoxication. Right. So there may be something that we don't usually seem is a hazard, but we may have to remove some things from that, right? Remove stimulus. We may have to turn the radio off. We may have to go to a place where there isn't a TV on. We may have to do something in a spot of the house to where it is as blank and as bare as possible. So we want to communicate clearly and concisely, and we can use that by using simple terms and direct language. We can't go on and on about something. And we've all met that person that talks and talks and talks and talks, and we could have summed it up in one sentence, but they talked in a paragraph about the one. We don't want to do that for us. We want to make as clear and concise as possible. I see this. Here's what I'd like to do about it. If we don't do something about it, this would happen. That is kind of how we want to be setting up our conversation. So speak in a calm and steady tone and avoid sarcasm, jargon, or complex explanations. So we definitely don't want to be using clinical terms when we're talking to them. The other thing to do is use active listening. Okay. So most people are just waiting for their turn to talk. They ask a question, the other person's talking, they're not really listening to what the person has to say. They're just waiting for the break in conversation to tell them what they are thinking. When we're using active listening, reflective listening, we want to make sure that we're listening for meaning. We're listening to try to understand the core issue for this person, right? And we're going to work on validating the feelings and not delusions. And I'll talk about why later on again. So before we get into that. So validating is something that we can all do for everybody. And deep down, when we talk about that Maslow's hierarchy of needs, next to having housing in a safe spot, most people at the bare minimum need to be validated. They need to be understood. They need to be affirmed and appreciated. And we can do that with people or crimes, right? And that's what I had to learn in the community protection group homes, to separate crime from individual, because when you hear terrible things, it's hard to validate somebody who's doing something that's not acceptable, right? But we can still do it. You can understand why they would do that or their rationale from doing that. So we want to validate people's feelings in that. But at the same time, we have to set clear boundaries. There are some things that are not going to be acceptable in your houses, and there are consequences for that, right? So when we do that, we have to, for example, I need you to lower your voice. There are other people in the house, and if you can't, we are going to have to ask you to leave, right? Those consequences have to be clearly stated, as well as the behavior that is the problem and what we expect them to do about that. So to do that, we have to be assertive in that and set very clear boundaries and stick to that. So if we are going to do that and feel the need to set a boundary, especially if safety is in the mind, if we pull that card, we better pull it, right? You can't set yourself up to where I gave you an explanation and gave you a boundary, and then you cross that boundary and I don't follow through with that. So again, we're going to have to pull that card if we do set that. And then practical support and risk management of that. Okay. We want to encourage somebody during that time to seek out the help that they already have. If they have a case manager, if they have a med provider, if they have somebody already, can we contact that person? Can we get them involved in this? If they don't, can we help find them one? Can we help? Some of you may have behavioral health agencies already attached to your houses. Some of you may have them as contractor providers in the home, right? Let's use them. Let's get them on the phone. And if not, let's help that person set up an appointment with one, or call the crisis team or a mobile response team, somebody that we have that's an alternative response team that can come out and see that person. We then have medication adherence. So if the individual is known to be prescribed medication, we may ask if they've been taking them. Maybe they started cheeking medication. Maybe they're hoarding them, right? So we want to open that without making accusations or doing that, but ask the question of, have they been taking their medication as prescribed? So we can ask that in a way that's not accusatory, or we can ask that in a way, or why haven't you been doing this? Are you doing that? Right? We can frame things in a way that is more information gathering than accusatory. We also want to reduce stimuli. And this is something that we talked about, is lower noise levels, right? Turn off radios, turn off ringtones, dim the lights. And that's where we talked about a bare room. So offices that are free from clutter. And we want to make sure that we are monitoring risky behavior. So if we have seen signs of impulsiveness, if we have seen that they are spending all of their money for the month on reckless stuff, or they are driving off in a fast, reckless way, we want to make sure that we are monitoring those type of things. And that's for our own liability as well, that we are, one, documenting that. And if there are safety issues, that we are kicking them up the notch and notifying crisis, notifying our management, notifying the powers that be if there are criminal activities, that maybe we're notifying law enforcement as well, especially if there starts to be self-harm or harm to others that we're seeing as well. Okay. And then we have support basic needs. So if they're eating, drinking, those type of things, we want to make sure that there's adequate space for them to rest or sleep. So if they need food, they need water, we can encourage those type of things as well. So engaging with supportive systems and crisis intervention. So we all have support systems, and we want to give the person the opportunity, and maybe without taking it personal, maybe we're not considered that, right? Maybe that person has somebody else that they trust more, that they would like involved in this, right? So if it's appropriate for the situation, we want to give that person permission to get a significant other in, or a family member in, somebody who's a close friend, a sponsor, somebody within their NAAA group, somebody who they've dealt with in the past, a past provider, anybody who's in that support system. If there's somebody that they would trust more and it's not us, let's ask to call them. Let's ask to do that. And that's why I love crisis plans, because you would have access to know exactly who those people are, as well as their role that they would like them to play in that. So if you already have crisis plans for these individuals, and it comes a time like that where you're not the trusted person, then I know where to find them and I know how to get it. Back to that safety plan. I love crisis plans. I will tell you that if your residents don't have crisis plans, and we did webinars on them before, they are awesome. It's empowering for the person to do, but you don't have to make the suggestions for them because you've already done it and you can reference it. So if you haven't developed a safety plan, that may be time to do that, right? Maybe time to talk about what to do for that. So have they ever experienced mania before? And in the past, what helped them? What stabilized them to do that? What things made it worse for them? What should I not do during this time, right? And this can be an active conversation while the person is, what are things that would make your symptoms worse? What are things that would make them to the point to where we're going to trigger trauma or trigger PTSD issues? What should we do and what should we not do? The other thing that we want to do as staff is know our local resources. Even though we are all, most of us in Washington State probably, the counties and cities drastically have different resources available to us. So you may have absolutely no outreach teams. You may have no alternative response teams. Maybe the only thing you have access to is crisis. Maybe there's no diversion programs or deflection programs, whatever that may be, but you are going to have to know your best to know these resources. In addition to that, we want to know and keep up to date on them. The minute something hits the press and it gets printed out for you, that minute is something changed on there. The resource changed, the insurance changed, the location changed, the population changed, the funding source changed, whatever that is. So the more you can know what's available in your community and to offer that practical help, the better. And when to call for help, right? We never keep threats to self or harm secret. We never not document them, and we never not call on them. Okay, so if somebody is truly threatening to harm themselves or others, we're going to do something to call for help in that. Same with extreme agitation or aggression. If this escalates to the point where chairs are being thrown across the room, right? If they're damaging their own property and they're doing it without harming anybody, that's different than throwing and breaking windows in your home or tipping over couches or desks or something like that, right? Then we have severe psychosis. One of the things that we talked about a little bit and we'll talk more about right now is command hallucinations. So command hallucinations can be very dangerous because the person is being told, you will do this or something bad will happen. So if the person feels obligated because this is God talking, or because it is, a head religious figure, or because it is somebody of mass importance, and they don't do what happens, there may be consequences to the whole house dies. Their family members will get killed. The world will end. And if they believe that, and that they're solely responsible for making sure that the world doesn't end, they're going to be likely to carry out whatever that command was for that hallucination. So asking those questions are, do you know the voices? Do you know who's talking to you? Do you know what is it that they're asking for? What do they want? Asking questions like that is more than appropriate, and it helps understand that the person that you are actually seeking to understand, not judge them or criticize them for that, right? So same thing with paranoia and delusion, similar. And do they have an inability to care for themselves? Or are they drinking, eating, maintaining their hygiene? This falls into that grave disability category. So you may have heard that's usually the third category for the Involuntary Treatment Act, what your designated crisis responders are under on when somebody will be detained. So the three criteria is danger to self, danger to others, or grave disability. So if the voices have told them not to eat, not to drink, and they're going on day 3 of this fast or whatever it is, we need to know that. That may is directly due to their symptoms, which falls into the category of grave disability. All right, so how to help with psychosis. Again, similar to mania, we are going to remain calm. We are going to answer questions in a calm manner, and we are going to try to mimic our voice to match theirs, not their elevated or their rapid speech. We are going to slow ours down. We've all seen this when you sit a certain way and I put my hands on my face, pretty soon the other person I'm talking to is going to do the same. If I cross my leg and they're sitting across from me, they're going to do. We talk about mirroring, and people do it all the time. So sometimes we do it with rates of speech. So if I can have a slower rate of speech, the person who has a longer, a faster one, okay, will most likely, hopefully, start to mimic mine. The other one is comply with reasonable requests. If they want a glass of water, if they want to call somebody, we can do that. Okay. But we're not going to take a break to get on Tinder because of whatever it is. We want to, it has to be reasonable requests that we will meet during that time. Otherwise, we're worried about our safety, their safety, and other safety. So again, one of the things that we teach in de-escalation too is maintain your safety and access to exit. So if we are going to pull this person aside to have a conversation with them, usually architects don't design homes or buildings with safety in mind, meaning that we are in the back, there's a desk in front of us, and the patient is there, then the door, right? That means worst case scenario, I got to go over the desk through the patient just to get outside of the door. Okay. So if we are pulling people into certain rooms and having these conversations, we want to make sure that they can see the exit, we can see the exit, that both of us know that there's a clear path, that we're not trapped, especially if paranoia and delusions are in there and they feel like you're in on the delusion and you're in on the paranoia and they don't feel safe with you. It's going to be really hard to listen to somebody when they're worried that you're going to shoot them with a needle, or you're going to hit them with a dart gun, or you're going to take their brain, or whatever part of delusion may be in there. So this maintains for both us and them that we want to have access to an exit. If you don't have that in your house, think about that on how to set that up to where when we need somebody to come into the office that we can have clear exits for both parties. We don't want to do anything to further agitate the person, so we want to use our best to use positive language. You can see this when you talk to kids too, when you're trying to give a message and you use a thing, something like, oh, you're stupid. When you, they stop listening to the message, they just heard stupid, right? So it's out of sight, out of mind, even though we could be getting all types of life-changing information and everything we say is valuable. We used one negative word and that's what they focus on and that's what they think. So if we can replace those negative stuff with more positive words in nature, again, we want to talk to people who appear to be in charge and appear to be confident. So if you are nervous and you're fearful, that's going to come out, right? So we got to do our best to try to maintain our ability to stay calm and stay cool and collected. The other thing, of course, we don't restrict people's movements, and be aware that what may, and that's why safety plans are important, that may exacerbate the person's fear or aggression. We don't want to continue that and make it worse. The other thing we have to be mindful of is we may not get this done in a nice, tidy ribbon and bow in a nice time frame, right? It may not be resolved in an hour. It may not be resolved in 3 hours. So we may have to take a break from this conversation or use a substitution technique. And I like the substitution technique because I can kind of gauge on where somebody would be. So for example, if I'm trying to de-escalate somebody and it ain't working for whatever reason, maybe it's my face, maybe it's my voice, maybe I remind them of somebody they don't know, whatever it is, we can put that back and say, I don't seem to be having a good interaction right now, or I don't seem to be getting through. However you want to phrase this, would you rather talk to somebody else? Is there somebody else who would be better suited to talk to this? That person can then say and give an honest answer of, yeah, I hate your face. You remind me of somebody I don't like. I don't want to talk to you for whatever reason, right? and I'd rather talk to this person. Or you can say, no, I'm sorry, I'm just really upset. I haven't slept in a few days, right? I haven't eaten. I'm agitated. I'm irritable. I'm sorry. I'll pull it together for this conversation. So sometimes we can use that as a de-escalation technique just to be like, hey, I don't think that I'm being very effective right now. Somebody else that we can talk to. All right, so I'm going to try to at least give you 10 minutes for Q&A. So I'm going to be mindful of the next 5 minutes and still get you this information though. So how do we communicate with somebody suffering from psychosis? Okay, there's some do's and don'ts are usually the more important ones. Okay, so we speak clearly and slower when we're talking to them. Unfortunately, this may be agonizing for you because you have to slow it down to the point where you feel like you're being patronizing, right? So, just how I slowed that down for you, sometimes you're going to have to talk in that cadence and in that very clear, and it may seem like it's torture for me to do, but you may have to break it down like that, right? So we want to be in that calm, clear, very slow way. We also want to show our hands and have our hands. We don't want to have our hands in our pockets. We don't want to have them behind something, okay? Because if I'm worried about my safety and the voices are telling me that this person is unsafe, they're trying to hurt you, they're trying to harm you, they're out to kill you, they're out to kill your family, if I can see that there's nothing in my hands, there's no needles, there's no knife, there's no gun, there's no dart gun, you can see it, it's more likely that they're going to pay attention to what we're saying. Okay. The other thing that we have to do is give one command or request at a time. So sometimes I've seen people, especially in correctional facilities, that they will say, yeah, you're right. There are aliens after you. And the only safe spot is in the cell. Go quick. And they go, right? We don't do that. We also don't tell people, okay, get up, put your clothes on, get dressed. We're going to the appointment. After the appointment, we're going to go shopping. And after shopping, we're going to take you to another appointment. And after that, we're going to. That's way too much information. We give one command at a time and wait for that command to be done. So if they need to get dressed, we'll say, please get dressed. And until they start to get dressed or until they acknowledge that, we don't give additional commands. Okay. So we do one thing at a time and wait for that. And we may have to repeat ourselves over and over again until they comply with that. What not to do now. Okay. So, what not to do, again, in this situation is extremely important. We do not agree with delusions. Okay. We don't agree with hallucinations. We don't agree with paranoia. And we also don't disagree with them. So even though it may, in the short time, help the person do what you're doing because you're saying, yeah, you're right. They are after you. Do this quick and they won't be. You are now involved in that. You believed me. You told me that you see it too, that you thought so too, and that you agreed with it. Eventually, those are going to be holes poked in that story, right? Eventually, they're going to find out that you don't actually experience what I experienced, and you're a liar at best, right? Or you manipulated me, or you were condescending, or whatever that is. The other one is that if I disagree with it, I am just like everybody else. Okay? I am always telling them those things don't happen, that I'm full of crap, that something's wrong with me, whatever that may be. So the safest thing is we do not agree and we do not disagree with any paranoia, hallucinations, or delusions. The best way to handle that situation is to say, I believe that you hear what you're hearing, but I do not hear that. I believe, and that sounds very scary to have those feelings, but I haven't experienced that. Is to be honest, is to tell them and rationalize and show some empathy that I believe you. I don't think that you're lying, but that's something that I don't experience. Because then we're still there to help them, but we don't get wrapped into where we are full of crap or we're just denying it or whatever that may be. So acknowledge that they're feeling that and be honest that you are not experiencing those things. And then again, the other opposite of doing one command at a time is we don't load them up with a bunch of expectations and stuff that they need to be doing. So when communication is difficult, we want to respond to disorganized speech by talking in an uncomplicated and succinct manner. So what that means again is slow it down. Okay. We want to repeat things over and over if necessary. And we want to be very patient and allow plenty of time for responses. This is uncomfortable. This is very uncomfortable for people, especially if you haven't experienced it before, on the response latency, meaning that it requires several seconds, if not minutes, to go by before you get there. Okay. The other thing I want you to do is never assume that the person cannot understand you, even if their response is limited. Even if they're getting little to no response, maybe they're catatonic, meaning that their eyes are on, but there's looks like there's nothing going on in there, or they're not responding at all. And I'll give you a tale from the psych hospital. There was a person in there who we deemed catatonic. They were psychotic and they were not responding at all. So this person did not respond to verbal commands. They did not show any type of nonverbal response to verbal commands. We were giving them antipsychotics, and for a long time, they appeared to be not turning the corner or getting any better, right? Now, this person did experience that, but staff just kind of went about their business. So they kind of just talked around the person, or kind of, did groups and checked in and just did whatever. Well, when that person started coming out of it and they started to be able to communicate, they were retaining any and all information that was going on during that time. So they were able to tell us, you know who likes you, you know who doesn't like you, you know who likes their boss or doesn't like their boss, you know who's sleeping with who, guess who's cheating on their wife. They were just retaining all of that information. They were able to understand exactly what was being said. It was all being recorded in their brain. They just weren't able at the time to convey that or say that. So even though this person may be experiencing psychosis, never assume that they aren't paying attention and aren't recalling who treated them like crap and who treated them well and who helped them and who didn't help them. So if I could leave you with anything, I'll leave you for that. Again, listening non-judgmentally. This is one of those things that, of course, but is a lot harder to do than it is to say. So we understand that these symptoms, we're not going to take them personal, right? That these are something that somebody's experiencing and they have nothing to do with us. And we want to understand that we try not to blame that person, criticize them, take their delusion or hallucinations personally, and definitely don't use sarcasm. Even if you are somebody who's awfully funny and witty, leave that out in this situation, because it can be used as patronizing and judgmental. So again, we're going to give that reassurance, treat everybody with respect and dignity, offer that consistent emotional support, meaning that if the person is unable and there are no crisis issues to talk about it now, leave the door open for them to come back and talk about this, right? We get that with treatment all the time. How many treatment stays, how many inpatient stays does it take for somebody to comply with sobriety or abstinence? It takes a long time. It may take multiple times. It may take multiple times of engaging with this person until they feel safe to talk about you about their mania or their psychosis. So we always want to leave that door open and provide some practical help in the meantime, give that reassurance, that hope with, is what we call that, like hope, rather than information. We don't tell people what to do. We tell them what's available and what they can take advantage of if they want to. So offer that information and never once ever make any promises, okay? Meaning that go here, take your meds, it'll be fine. Don't do this, do that, because we don't know what works for that person and won't. So never make any guarantees easier. All right, so sorry, I get 7 minutes for questions. So went a little bit over on the allowed 10 minutes, but feel free to either come off mute and ask, or you can put that in the chat if it's something that you want to send me directly, and I will do my best to admit anything that shouldn't be in there.
Cameron, can you, I don't remember, we talked at the House Leader training when we were in Bremerton, and I asked in your presentation then about the relationship between designated crisis responders and EMTs and the police, and how that trio needs to kind of come together. I told you about a particular instance where we had called DCRs for a gentleman, and the EMTs came, but the police wouldn't come. He said, that's just him. He's always like that. And I was like, no, we need you to be here because the EMTs were not able to actually physically take this person and put them into the back of the aid car. The DCR had, said, yes, this person needs to be taken into the stabilization center. The EMTs came, the police would not play. And then I finally got them to come. And it was difficult to get the whole thing together. Can you, I'm sure everybody on here probably has had times when they've needed to call designated crisis responders, and there is some protocols in play for them of what they can and cannot do. Could you kind of walk everybody through that?
Sure. Now, everybody is under RCW 7105, if you want to write that down, and RCW 7134 for youth and adolescents. So that is the revised code of Washington that they have to follow. So the more that you know that and can speak that language, they won't be able to bamboozle you and tell you I can't.
Can you say that RCW again?
Yeah, it's 71.05 and then 71.34 for adolescents or youth.
Okay, thank you.
Yeah, so the more you can get familiar with that, and those are hard reads, but the more you can talk, the more they can't tell you what they can and cannot do, because you can say, well, the code that you follow actually says this, right? And never take a line staff's response. Ask to speak with supervisors, and that's the same for law enforcement. Ask to speak to the sergeant on shift. Ask to kick that up. If you are not getting the response that you need, kick that up the chain. Never once, because sometimes, and this doesn't happen all the time, and I don't want to, I've managed crisis services for years. Sometimes staff don't give you all the information. Sometimes they don't tell you, but in this scenario, we can do this. They just say we can't do that, right? Or maybe it's a bad day, maybe they're busy, maybe they got stuff lined up, whatever that may be. You never take that as an answer, especially if your safety or the safety of your residents and other people that you're serving are there and you need some. Don't stop with a simple no. Kick that up. Know the laws, speak their language at times. No, this is grave disability because of this, so on and so on. The other thing you can do is, worst case scenario, you have kicked that up the ladder and the police said, yeah, we're not. And you went all the way up to the chief. And then the CEO of the company said, yeah, we're not coming out from a crisis standpoint. There are other means like Joel's Law that you can then pursue. And so you can get direct testimony from the people in the house, their family, your staff, whoever that is, that can provide real world examples that, hey, we've called 911 20 times in a 2-week period. This person needs help and nobody is helping us, right? So then a judge will take that info, ask for the documentation from crisis, especially if they've been refusing to come out there. There's no documentation on their side that justifies that they've even done an evaluation. The judge will be more likely to grant that order, and then the person will get detained to whatever facility they need to go to.
Mm-hmm.
And then we got what is your thoughts on inducing psychosis, causing schizophrenic episodes to diminish an addict's capacity so that their family may involuntarily commit. I have not been able to speak with Deanna, so maybe you could enlighten me. So what are your thoughts on inducing psychosis? There's a lot that can induce psychosis, right? The most common ones are going to be lack of sleep, lack of food, lack of taking care of the person's self. The other one can be, and marijuana gets a bad rap that it is causing psychosis. It is not causing psychosis. So just because we smoke a joint doesn't mean I'll go psychotic. It means that people who are predisposed or have had that may get pushed over the edge in that. So whether it's legal or illegal substances, kratom, stuff they can buy at the gas station, spice, anything that they can do or ingest can push them over the edge, especially if they've been predisposed genetically, or it just takes a little nudge sometimes. So that can happen all the time, depending on what that is outside of just normal stuff that you would think, well, it's legal and you can buy it at the gas station. That doesn't mean that it's good for them to take and could result in a psychotic episode. And then for family members, for the involuntary commit, what we want to do for that is make sure that we have releases of information for all of our people, right? And I'm assuming that you do, but I've got to get that first and foremost, to where we can speak to people and have conversations with them about very specific things that may be touchy subjects, and have that. Because if we need to reach out to family members and get direct witness support, because when we do a Joel's Law, for example, or we do petition the courts, it can't be hearsay. It has to be direct witness. So the cousin has to say, I saw this, I witnessed this. It can't be somebody told me, mom told me, dad said this in the past. It has to be a direct witness, and it can't be hearsay in that. Did that answer your question, hopefully? You're welcome. All right. Anything else for
One
the
more
good of the
question
order?
if nobody hops in.
Go ahead, Connie.
Just curious, just in my experience over the years, in having folks with schizophrenia, in your experience, and this is just a curiosity question, even when they've been on medications for schizophrenia, that the hallucinations still tend to persist. And I'm just out of a curiosity why that would continue to happen for folks. If it's just hard to treat, or I'm just curious.
Yeah, the medication won't make it go away. It's not like magic to where you don't have it. It does make the symptoms more tolerable for them to live a healthier life, right? And to function. So it does help decrease the intensity of them, but it won't make voices go away completely. Right. So they still have to do some other stuff, still have to, that's why taking care of themselves, doing the best they can for food, sleep, rest, and not taking things that would trigger more psychosis. But the medication isn't going to cure that and make it go away. It makes it more tolerable. And yes, there is a 8-hour de-escalation class on there. But that was the class that I mentioned. We were covering de-escalation in like one slide, but really it's a whole class worth of stuff. All right. Well, thank you, everyone. This was enjoyable and lots of interaction. And so thank you again for your time and allowing me the opportunity to present to you.
Cameron, when was that class, or when is that class?
I mean, I could I do that class for law enforcement. I do it for behavioral health. It would just have to be scheduled.
Okay.
It's easier to do in person, but yeah, that's something that we could figure out if that is anything that you want to work.
Okay. I'll go ahead and I'll definitely talk to my supervisor, because all of this information can greatly help us here at OVHC. So that's awesome.
Yeah, anytime. I'd love to do that.
For sure. Thank you.
All right. Thank you, everyone, for joining us today. Cameron, such a wealth of information you shared. Yeah, and so we'll be sending out the slides probably in the next week or so, and the recording will also be posted on our WAQRR webpage. So that's www.waqrr.org, but I'll send it out via email as well. Feel free to email if you have any questions. All right, everyone have a great day.
Thank you.
Bye-bye.
Thank you.